Well, thank you, Dr. Monch, for your kind word, but actually thank you for your team. Thank you, Brandon. I still do for you to kind of push me in, which is a term we use in our office, being pushed in, to our behavioral health integration, session. Um, Before I start, I just want to do a quick poll by show of hands. How many of you here represent a small practice, like full-time employee, probably, or I should say full-time employed providers, 5 or less? 10 or less? Okay, all right. So I have a few more there. How many of you are physicians or PA or anyone who's doing like direct, is that you're a provider giving medical care? How about nursing? Behavioral health? Other than Dr. Smith, any licensed psychologist? No. Also, human resources administration? Thank you so much. Or how about none of the above, or you don't know why you're here? Okay. No, I actually talked to this lovely lady. She's here from the union, right? Yeah. Thank you. All right. So we'll make this work. Yeah. Good. My first slide is objective. That's to help me, to remind me why am I doing what I'm doing now in front of you. But more importantly is what do I want you to get out from this. Hopefully you will take something back to where you come from and really be excited about using some of these things. So before I even start, I think what may draw your eyes like opening a can of Campbell's alphabet soup. See all the acronyms there. And why I insisted to someone early on, when I submit the title, I insist on putting acronyms there. The reason is very simple. It's my personal experience when I first attended some of those earlier meetings, like the 8 o'clock meetings with this rep and all. I feel so intimidated, confused, and overwhelmed with those acronyms, and I walk out of it thinking that I suffer from AOS, means acronym overload syndrome, a term that I made up. And so I just want to tell you that this slide have a little bit more of that, but I'm going to, of course, give you the original term. The objectives I lay out is introduce you to Koinonia primary care, fee-for-service, and behavioral primary care behavioral health co-location is our first experience, but then we travel then to value-based care and the collaborative care model. Towards the end, I would like you to see if our tips and tricks would be helpful to you, and also some challenges that as we are getting ourselves prepared to this kind of new payment arrangement. What is in the name, that which we call Koinonia? You must know and should know by now is the 2018 National Spelling Bee winning word. It's a transliterated form of a Greek word, which I would not know how to pronounce. But it really, I embrace the meaning, so our staff, about intimate communion, sharing, association, partnership, often with a spiritual implication. And for those who share a Judeo-Christian faith, it's like an idealized state of fellowship and unity that should exist among people of faith. So that's the definition. As we go to work, we are reminded of our mission is striving to eliminate health disparity within New York Capital Region by providing compassionate, high-quality, patient-centered health care to the underserved in a faith-based. And for the mission has been clear from the beginning under the leadership of Dr. Bob Peglow, the founder and the medical director of Koinonia. Let me introduce you to our team. I think they are just awesome. They're a dedicated team of professionals, staff, and volunteers. This is us together in April, And then after that, Dr. Corey Paglo, our new executive director, and Cassie Flanagan, our new office manager, also joined us. I think we are either known for this or working towards that, is to be more caring, committed, big on volunteerism, respect, stewardship, community involvement, and empowerment. Look at this picture. This is where we go to work every day. It's a historic building, 130 or 40 years old now, located on 553 Clinton Avenue in Albany, West Hill neighborhood. Now, some of you may have just gotten a house or have the experience buying a house. What does your realtor tell you when you go get a house? What's the most important thing? Location, 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 right? I think Koinonia got the location. It's located in the west of Arbor Hill, corner of Clinton and North Lake. I say we have the location because it's the prime area in the Capital District to practice collaborative care and to promote population health. So let me tell you something about our neighborhood from some very new data. West Hill is known for crime. It is worse in Albany between 2012 to 2017. The first 8 months alone, there has been 384 arrests, 3 murders, 6 assaults with a weapon in the first 8 months alone. The first homicide by shooting of 2018 took place at the traffic light just outside of our clinic. During lunchtime, we heard the gunshot. News Channel 13 actually featured a story just 3 weeks ago, I think, titled "Left Behind: Crime in Albany's West Hill Neighborhood." There are more to that. Albany is known to be the worst among 100 U.S. metropolitan areas for Black, non-Hispanic children to be raised. Where's my source? The Child Opportunity Index 2015, developed by the ICYFP of Brandeis University. Nationally, an average of 40% of Black non-Hispanic children grow up in lowest opportunity neighborhood within the metropolitan area. In Albany, 60% of the children live in such neighborhoods. And I'm sorry, Dr. Vasquez, we beat you on that statistics. We beat Buffalo. This is the source if you're interested, or you can come to me later, because when Paul Tonko actually visited us, he was very intrigued. Where do you get that data? And a lot of people were surprised. Actually, Samoan get the prize. So I just put it out there so that you know we are serving a highly traumatized and highly demoralized neighborhood. There's no reason for them to believe in us and trust us, really, very little. And so we have been there for 16, 17 years now, and just started, I think we just get it started. Meet our patient, please. Many of these patients, they live in the neighborhood, this highly traumatized neighborhood. We have completed patient visits in the last 12 months, close to 9,000. 2,130 of them are active patients currently, so we are quite small. And I forgot to tell you, we have altogether 11 full-time staff. Some of them are job shared. Those people who work hardest, actually, they are volunteers. Among the 11 full-time staff, we have 3 providers. I'm one of them. That's how small we are. So in terms of the demographic, if you look at the ethnicity, we have 88% non-Hispanic, 6% Hispanic, and 6% unspecified. In terms of race, we have 42% identify themselves as Black or African American, 40% white, 2% Asian, and 16% other races. Gender split is almost even, 49% female, 51% male. Age distribution, 5% 18 years and under, 85% adults that are up to 65 and over. One more slide on this one is the insurance types. We have, if you combine the Medicaid product, we have 52% of them, and the combined Medicare product is 19%, And those people who are on commercial non-Medicaid plan is 23%, and no insurance or self-pay, meaning they just cannot afford to pay, actually is 6%. All right, this preference bar chart. Comparing to the national estimates, there are a higher prevalence in several common chronic diseases such as obesity, depression, asthma, and COPD. My purpose of putting this slide up is really just give you a broad stroke, the landscape of the chronicity and the need just based on medical behavioral health alone. They give you a kind of like glimpse of how unhealthy our population are. A note of caution though, anytime when you retrieve data from like CDC, which National Center for Chronic Disease Prevention and Health Promotion is one under the CDC banner. It depends on how you define the metric, depends on when you draw this data. So the data can shift, like the depression, for example. This is this chart was made for January 2018, I'm sure, one of the data submission we have to do. But if I draw the data using the same metric today, I just checked yesterday, actually it's 17%. So when we drew it, it was 13%, okay? And I'm not talking about PHQ-9 above 10, because if I use that data, it's around 30%. Oops, wrong button. All right, so when we opened the door, we thought that we knew what we are getting into, and we are driven into that community. As I shared earlier on in the panel discussion, we are really compelled by our faith and driven by compassion to just meet this head on. So we knew what we are getting into. So we thought kind of naively that seeing the patients as often as they need to be seen meant better care. And then we're like, oh, okay, for the mental health part of it, that's easy. We just co-locate psychiatric provider, right? So this is our simple co-location model. And like anyone else, the primary care and the behavioral health providers follow the fee-for-service model. We didn't know anything else other than either self-funded or fee-for-service. And I know that Dr. Bob would chastise me for saying this, but he did not draw a single paycheck for the first 10 years. So what's wrong with that? Well, the features of fee-for-service is we all know paid for volume, and quantity over quality is more emphasized. More care, more frequent care does not necessarily become better care. Silo work, I say hi and bye with Dr. Bob, doing those era a lot on the elevator, but we don't really talk that much because he trusts what I do. I trusted what he did, so we don't really need to talk that much. And it's issues focused, individual focused. But what's missing in the picture is there are little or no measurement of quality or emphasis of evidence-based care. There's no little emphasis of health of the population. And even with us, the co-location is going on, there's no systematic care coordination. It's difficult to track sustainable progress or lapse of care. And frankly, who got the time? So that went on for around about 10 years, I would say. So after years and years of trying to make it better, I'm on the first floor, he's on the third floor, and somehow our patient just don't know where they went, because right after he referred to me, they just disappear in thin air, or they just don't follow up the care. So in 2012, these years are important because this is before we became a nonprofit, Article 28, way before we became PCMH, way before we heard the term VBP. And we decided then that's enough. We have to move away from the co-location towards collaborative care approach, or start to attempt to fully to moving towards full integration of primary care and behavioral health services. We have not looked back since then. Because for us, value-based care and collaborative care really goes together. I would say back then, I'll say today, I'll say that even if there's no funding coming, that still go together. There's no health without mental health. Thank you. And we also see it as well as sense that the what's so great about the integration is because it enhances the patient's experience, right? There's less of the stigmatism now. They don't have to disappear just because the behavioral health person is coming in. They don't have to go to my office. I would go to them. In fact, the warm handoff being mentioned in a later graph, practically speaking, we don't do warm handoff. The patient actually sit where they are, and I got pushed in or I got introduced into it. So obviously, when they are compliant to treatment and coming back for the follow-up, the treatment outcome is starting to lighten up. And then when we are able to do it consistently now across the whole population for those who need it, then we see that the health, the atmosphere about among the patient actually also improve. It saves health dollars, and it satisfies us because we're easy to please. If our patient is doing well, we are doing well. We have no idea, or to be exact, we have no care really about the financial implication when we first took this on, which is, well, just do it and then see what happens. And so I'm so sorry, I'm saying all these things that kind of like make Joe Conti's slide, either I lie or he lied. Now, a lot of you are familiar with triple aim, quadruple aim, right? And it's so tied into healthcare, but also definitely value-based care. While we are doing what we were doing, trying to figure it out, in 2007, AHI, Institute of Healthcare Improvement, a nonprofit organization in Boston trying to improve healthcare globally, came up with triple aim, wanting to simultaneously focus on the quality care of individual patients as well as the quality of care of population, while maintaining a reduced cost per capita of health. Then recently, quadruple aim kind of like piggyback right on this triple aim model. Now they started to talk about, well, if the providers are not happy, then that's really not a full spectrum of best practices. So they have that. Now, we know none of those until we started coming to webinars and stuff like that. But what we find is a very simple way to look at it. We want everyone to win. So we have the triple win. We win, or the patients win, if they had good experience, seeing that they have good care, but also start to have good control of their health. And again, we see this as a winning situation for us because now we are really doing what we are supposed to do. The carriers win, I suppose, is because we save them dollars in terms of inpatient and ED or whatever. But really, the gist of that win is because of a lot of personal sacrifices, which I highly not recommend, but that's how we did it. Now, I don't expect any one of you can read this. This is not an eye test, so don't even try. But this is a flow chart that we didn't have when we first started in 2012, but we worked towards it and kind of push into it when one of you guys say, hey, do you have a flow chart? Well, this slide is up here just for another sec, just to tell you that we do have some kind of protocol. It is a busy-looking protocol, but it's very easy to digest, and I'm going to just give you a piece of encouragement. It takes years for us to grind this out. I'm not saying that, pulling that from the clearinghouse is easy. But really looking at ourselves in the mirror, are we doing it? Is it sustainable? How does it mean in the buy-in culture of our front desk, the billing staff, or myself and my team? So we kind of grind it out for quite a few seasons. So don't be discouraged as long as you know that it does take time. And also with this, now we can say that at least in concept, we have a consistent of care. So I cropped the first half of it. Maybe it'll be easier for you to read. What we are talking about here is every time a patient checks in for an appointment, the front desk staff will ask the patient to fill out BHNNY and GAD7. That's the 2 blue boxes up there. And during that time, at check-in also, now we give them Order C because now we are expert certified. So if the patient who has SUD concern, then we will do the expert procedure as well. For a new patient or a patient who come in for annual physical, if we find that they don't have MDQ and ACE, which is mood disorder questionnaire or adverse childhood event, we'll want them to fill in once as a baseline, because after all, they are from a very highly traumatized neighborhood, so we don't take it lightly. That's not to say that whether they have PTSD or not, that's beside the point. We just want to know how we should be sensitive in approaching certain issues, especially if they're going to talk therapy. So the front desk staff will collect a completed form, enter the data. We have patients who really absolutely hate it, so they sneak it into the examination room and then will sneak it out. But we have a second catch, which is our nursing staff. And so we would get those data not only because we know that the funding organization asking it. In fact, I think OMH said, well, don't fill it out every single time. I know, but we have a disclaimer there. It's all, done in the discretion of the physician and the provider. So we said that we have to fill it every time. It really helped us to track, and you can tell later when I show some of the slides. And then, so there's a sorting process now. We saw how the scores fall, and for those who are 0 to 9, sometimes these are people who may really have no problem, and some of them are very under-reporting kind of personality. Some of them have dysthymia. Whatever it is, we would, seize the opportunity to talk to them if they have concern. Maybe even just psychoeducation. Should your 9 become a 10? We want to know, right? Then for those who fall into the moderate 10 to 19 is moderate to moderately severe, or the 20 to 27 category, then we definitely want to have an encounter. If we are busy, which you would see why I said that later in one of the slides of scheduling, then at least there would be an introduction saying that, hey, when you check out, within 2 weeks for the folks between 10 to 19, score 10 to 19, within 2 weeks, they would come in for integrated. For those who are severe, we want to see them back within a week. For those who also make it positive on question 9, then obviously we want to check what is the risk level, as well as any kind of safety plan need to be made. This is the bottom half of the flow sheet. What it is after we sort them and they come back now, again, the blue boxes, this is a returning visit. Especially for the folks who are prescribed with antidepressant, we don't do 1 month later, we do it within 2 weeks. Partly is because the first 2 weeks is a true test. These are patients who would say, I am hurting, but they are not willing to take medicine, or they are skeptical about it. So within 2 weeks, if they take it, great, and we will check whether there's any side effects of the medication. If they are not taking it, we still be able to catch them early on enough to track them and to talk to them a bit more why the reason they don't take it. But also there's still a very good time to start the talk therapy. When you move towards the bottom, now that is almost like 4 sorting basket, maintenance phase. It really depends on where the score drop range is. So after a few times of return visit, the integrated visit is when the doctors and the behavioral health specialists will have a chance to meet with this patient in the same visit. But then once the medication is stabilized and they really would like to invest more time in talking to the behavioral health specialist, now we are getting into just collaborative care, meaning just talking to one behavioral health specialist. So that is kind of marginalized, stepping into maintenance phase. Now this patient is stabilized, maybe they have a score drop of the PHQ-9, 5 points, maybe 10 points, maybe a lot. So it depends on how the decrease of that symptoms, then we'll decide whether that person will be seen still weekly or twice monthly, or just monthly. Maybe relapse prevention is more like the score drops even below 5, which is a better score than my score. So I would, say, okay, prevention, relapse prevention, just 3 monthly. The question we get asked ourselves first and other people ask us, is collaborative care better? So let's look at data that is done by other organizations. Montefiore team, head by Michelle Blackmon, had published something in just a couple months ago. Looking at their sites, I think it's 200 plus patients, they saw greater reduction in depressive symptoms found among patients treated by a collaborative care model than a co-location model. And from baseline to follow-up, there are 33% reductions in PHQ-9 scores for the collaborative care model versus 14% for the co-location model. Then there's a study by Gilbardi, 2017. He looks at, his team looked at 705 older adults with subthreshold depression symptoms and showed that collaborative care compared with usual care resulted in a statistical difference in depression symptoms at 4 months follow-up. And most importantly, we think so. So why do we think that? To remember that amazing retired engineer, I mean, he's actually my age. He disciplined himself to be able to retire early so that he can work on a field that need his help. So we said, Andrew, we really want to know if this is working. So what did he do? He got into the clinical and he tinkered with it a little bit. And then he went like, well, does this one look good to you? So what it is we can actually pull out a flow sheet graphically for each patient. And obviously I conceal the name of the patient and I type over the patient taking medicine part just for this presentation. But this particular patient is a 45-year-old black female with diagnosis of bipolar disorder. She has a long history of non-compliance with various programs and providers. Some comorbidities include chronic low back pain, insomnia, and palpitations, as well as, of course, later find out that she is using drugs at the same time. So, I mean, illegal drugs. So we open up this graph, this flow chart in front of her. So, well, look, what's going on? You were doing great or better. And then even after that arrow was put there, the 5, she did well when she took her medication. And when we ask her, why are you not taking medication? So, well, because I want to use street drug. So I don't want to mix them because it would kill me. So, so we can use this to say that, okay, when the person follows the protocol, things are better. The next patient. This is a 55-year-old black female with major depressive disorder comorbidity include a condition that I don't know how to pronounce, is INIP, someone who have to carry the oxygen. So anyway, so she's also morbid obese as well as suffer from sciatica chronic pain. She has been taking medication up to the point that I put the arrow there, but it's not quite touching it. So finally, I literally got pushed into that meeting and started talking to her. And the next time I saw her, she said that you basically, turn on a light bulb in me, and since then, she has continuously been doing well. So Dr. Bob already started doing the work by giving her the right medication, and now with the integrated, she is doing really well. One more. Now, this one is a bit busier because now we need to submit data to regarding anxiety as well. So now we also have a flow chart for GAD-7. And this particular patient, she is 52-year-old Caucasian female diagnosed with major depressive disorder. And she was, her depression was in full remission for 7 years. She had a history of eating disorder, and now she's obese and with some unresolved childhood emotional abuse issues. So before that data point A, she was doing fine, and then now she suddenly, had this depression coming back to her, and so she struggled. She didn't want to go back to medication, but you know, at point A, we started antidepressant. Point B, I got introduced into the integrated visit, but that medication doesn't seem to stick, probably because she had a long, you know, a history of taking medication, so we changed medication, then we changed dosage, but I stayed with her the whole time, and now she's doing great. And the, you know, down there, the GAD is just to tell you that her condition is more depression-based, not anxiety-based. So Dr. Vasquez asked me, you know, would I talk something about very-based payment and whether we have overlap or not? I assure him, I really have a couple of slides on this one. We are, you know, EPC participant of CDPHP. I was hoping when Dr. Bennett was speaking next to me, it's like, say more, so I can just run through these slides. But so I'm going to tell you what I know about that. I cannot be a psychologist and a builder at the same time, but so what I know is EPC is the proprietary name for the CDPHP PCMH. The rationale behind it is to combine saving associated with better health outcome and lower utilization, and that saving should be sufficient to fund enhanced compensation to PCP. So the shift now, of course, you have heard a few times now, the focus is from volume-based care to value-based care, as long as provider is providing care that is right and evidence-based at the right time. Monthly capitation payments are calculated based on severity-adjusted base compensation payment methodology, I think it's like an algorithm, like calculus. So I don't even try to explain how they come up with that. And an annual retrospective performance-based bonus is awarded to high-performance providers based on value and quality. Now, meanwhile, though, the standard fee-for-service is still applied. It's not like, you know, we are you know, not doing any fee-for-service at all. But that part of the income is not included in the capitation-style payment billable codes. And I'm so gratified after the panel discussion just now that I turned to Dr. Bennett about this particular point that is really scratching my head. There's so much talking about, so much, you know, positive talking about, you know, collaborative care, integration, but don't you know that it is not a billable codes in CPC and EPC? Meaning, just because we're doing elaborate collaborative care, EPCs does not directly benefit us. It does benefit the practice because there's still that primary care, you know, portion of it. But if I'm doing collaborative care, meaning if that doctor doesn't come in that time, that will just drop it down to fee-for-service. And so I asked Dr. Bennett, and he went like, talk to so-and-so, and it will happen. So we will hold it accountable. There are 60 of you, hearing me saying that, right? If you want to know more about this, really study it, or even get into it, visit that website. Now, so this, to be fair, the same question should be asked, is value-based model better? Data from the Centers for Medicare and Medicaid Services, Medicare Accountable Care Organizations saved more than $460 million in 2015 while improving quality and performance. That's their data. What the CDPHP say? In 2014, they realized a cost saving of $20.7 million across all lines of business directly related to EPC. $12.8 million more in reimbursements and enhanced bonuses among 193 medical practices than if those practices had not participated in the program. Our experience is looking at the Q4 of 2017, we had an increase of profitability of 30% associated with Medicaid patients and 5% with the Medicare patient. But should we trust them? Let's look at the West Coast. In West Coast, out in Stanford University, these two researchers, they are doctors also, look at one form of VBP model, risk-based payment models with capitation. Probably Dr. Vasquez is going to talk about more about the differentiation. And what is the risk involved? The number one is upside risk. It shares in cost-saving bonuses based on operational efficiencies. And the second one is downside risk. You lose that revenue based on failure to meet clinical performance. Practices that succeed at making a shift from
fee-for-service to managing risk are routinely able to increase their practice profitability by at least 25%. Okay, all right, so let's go. The saving comes from fewer hospitalization, fewer expenses, fewer of everything else that's seems to increase insurance dollars. And I still haven't answered this, get the answer. Hopefully Dr. Vasquez will give me the answers. Does this mean better care? Tricks and tips, because I only have 5 minutes, I thought that I can make you do this. But I can't. If you want to, you are welcome to stretch, okay? So what is the tips and tricks? You really need to know the patients. It's been said many times. I'm sure a lot of you know them through the PHI, the diagnosis, so on and so forth. But knowing them, to us, is really spending time with them. We don't do this often, only during summertime every week, so you're welcome to come and just hang out with us. We just really want to know them that we are their neighbors, know them that this is not a feeding program. This is a time when we just hang out, like we will hang out, open the grill, and hang out with our family. At the same time, we want to acknowledge them as individuals with creative capacity and inherent worth, not only their problems or the issues. So that turned from problem focus to asset focus. That's the ultimate goal. Really, after all the said and done, all the good work we have done, all the hours that we do, data and stuff like that, the ultimate goal is about human flourishing. If we lose sight of that, it doesn't matter how good we do. So some other program that we have really just trying to bring out this human flourishing, not by giving them things, but asking them to take control of their life. So if you come with $1, you can buy an item and then you can wrap it and be that Christmas gift for your child. And they feel good about it. Whew, enough about the patients, what about us? We know one another and the team as a whole. I think that's fairly important. And when you do that, you may be able to have a little bit of fun while working really hard. We want to emphasize the respect and defer to each team member's gifting, because we also remember none of us is as smart as all of us. We want to practice quadruple aim. When that lady before lunch stood up and asked about, trying to submit data, a lot of time I think the satisfaction of the team is to get the job done. And as it is now, the data sharing and all those stress that we're going through is not making us very healthy as a team. Make collaboration is a true practice, not just towards your patient, but as an organization. So you can network with other organizations, especially if you can't do much of anything else, such as we don't have community care resources. So, okay, we said, well, how can we negotiate someone to come to us so that we can do that together? I'm going to skip the next 2 slides. You can read this behavioral health integration issue brief series, and again, you can come up to me. This series this particular study we participate in just finished, and some of those actually this morning when I shared with you in the panel came from this study about how we, able to deal with data and data sharing, and we learned from this particular study. So let's talk about challenges. This is a typical Monday at primary care, Koinonia primary care. You will see that there's my name, Dr. Paglo, and Jeff Stark. All those are templates. There's no patient's name on it. Just to tell you that this is a typical day for us. When I blow it, zoom it in, that's me in the morning, Dr. Bob and Jeff. And so you see the collaborative care visit and integrative visit, and in between there's like that 15 minutes. Ideally is to do my notes, but it's actually gets sucked into, maybe I would take that patient to the Trinity Alliance office. Maybe Dr. Bob has a question for me. Maybe Dr. Bob said that someone is dying, I have to drop everything to... So there's that gap that allows us to kind of like go back and forth together. The point is, it's not just scheduling. I pick these challenges because it affects everyone. The front desk need to know how to place patients when they call. The staff need to know, when to bother us or not, because we are just completely busy all the time. And also, we need to know, for the billing person also need to know what is she billing. But it can be very stressful, but again, we have done this, we have tried different ways for 6 years now. This is where we have arrived. And if this is a headache you're dealing with, it's okay, it will get better, and you would just try it again and again in different ways. Overload is another issue, right? I'm glad that we talked a little bit more about it already in the panel discussion, but basically, very similar sentiment we see is we ask the same kind of data, but different organizations will ask it structured differently. And so, and then the two system doesn't talk to each other, maybe CMTS and ECW. So it becomes just a continuation of stresses. This is my last slide. There's 3 takeaways. Obviously, there's so many things I cannot possibly start to tell you within this presentation. But I just want to know we didn't get here without help, though. We identify what is important to us, and then we keep looking out for support. So just now, you saw it real time. I cry out, I say, look it, we have this need and we don't know where to take it to, and someone during lunchtime come and fulfill that needs. So I think I can start to go online to do a GoFund page now. First takeaway, VBP practice is a process that needs adaptation through time, confusion, sometimes it is, and perseverance, but it will get easier and better. Second takeaway, define what value-based care means for you and your community, and on point which you shall develop the workflow and adopt the logistics. For us, it's behavioral health and primary care. It's not because Joe Conti said that, it's because we identified that early on, and we are glad that there are wiser people who agree with us. Also, helping resources available more than you think through learning, sharing, reaching out. We are in it collaboratively.
I want to go back a slide. So my name is Dr. Raul Vasquez. I'm a family physician. I've been practicing for 26 years. So I think for me, this one slide here, let me see if I can figure out what the pointer is. This is where I felt like about 7 years ago was, how do I define that and how does it apply to my community? Because I've been doing the same thing over and over and not getting a different result. So for me, Mark Twain's definition of insanity was reality. And so we went down the group of trying to just organize things. So I started urban family practice, and we had a lot of patients. 90% of our practice is Medicaid managed care. So you're trying to survive in that model, and that model is very, very difficult. Because what I think of today, the fee-for-service world that you guys live in, you're taking on risk. Actually, if you want to continue those kind of models, it's great for the insurance industry because they save a lot of money, you work pretty hard, and at the end of the day, you won't be around too long. And I think that's the model. The rate limiting step are the providers. If there's no providers, you save a lot of money. So I'm going to tell you how we started. I'm trying to condense 3 years of work pretty quick. So there'll be some slides. We can give you guys the slides. So it's a lot of information. So I think when you look at accountable care organizations, I think for us, so the group of doctors, there were about 8 safety net doctors. We came together, formed an IPA in 2008, the Greater Buffalo United IPA, and that IPA began to do certain things. And eventually we thought we were going to grow up to become an accountable care organization. We became the first one in New York State, by the way, and we put New York State on the map for Medicaid in 2016. I think the key thing here was to really focus in on care coordination, the IT, and a lot of the networks that you have within your system as you develop this model. Now, The concept came by this gentleman, Elliot Fisher. So this is where accountable care came out, and then we all started kind of playing with this. But I tell you, it's a model that I believe will actually work. So we're probably the only accountable care organization that's a 4.0 version. And all these other ACOs that you talked about are 3.0. The 4.0 is very important, because what I mean by that is you're incorporating the social determinants of health, and you're tying in care coordination like health homes. Without that piece, ACOs really, they live in the commercial and the Medicare space, but in the Medicaid space, in order for it to be functional, you really have to tie into that, and the state's been learning as a result of that. I think the other pieces too is why an ACO, it protects us. It protects the organizations. Now, we're the only we're a for-profit ACO. I'm a for-profit. Everything we do is for-profit. And I think it's not a bad thing to be for-profit. And I think everyone says, well, when you're for-profit, it's only money. No, you'll have the resources to do the things that are real important. But here, I think the biggest thing is these laws, these stark provisions protect us. So as doctors, it's almost like creating a union. They never let providers kind of come together in a union. The ACO allows us to do that, as long as you cut costs, which is what we want to do. But it gives you the power to really have a leverage against insurance companies and anybody else you contract with. This is why it's so important. So now, as an ACO structure, you can have different agreements. You can buy it as a group. You can have customer relationship database. You can build together. You can save all that stuff and just share among yourselves. You can have imaging units and have those dollars come back into the system. That's not something that we've done in the past. Everyone always kind of does their own thing, separate systems, and that's unsustainable. Separate population tools we were talking about, everybody's trying to create their own. Yeah, you can do it, but you're not going to be able to sustain it after a while, and this is the best way for us that we found kind of works. So in terms of developing the transformation model, on the clinical side, these are the pieces that we put together. And a lot of it's based on patient-centered medical homes. I mean, that was crucial. But at the same time, the enterprise versions and what I find the ACO piece is all these other pieces you have to think about. We can't be a silo anymore. So as an ACO, all these pieces we work through, and I'll show you based on some of the data how we kind of play with it. And I was here last year, so this year is more of a description of what we learned through being part of a value-based pilot. And I'll tell you a little bit about that in a second. So again, on the operational side, we'll go through some of these things, but at the end of the day, the biggest thing is to really come up with a system that builds networks, that works with contracting, because now when you develop a model, you're marketing yourself, you're working to enroll patients, to keep them satisfied. They become consumers. They have a power. They can go anywhere. And if we don't understand that model, Amazon's going to teach us, because they're doing a pretty good job at it. And so, you're either going to be delivering little trucks for Amazon or working for Amazon if we don't come up with our own model. I think the key thing here too is when you develop these models, the neighborhood's real important. So you just can't do things in your box anymore. You really got to tie other systems. And churches have been very valuable in terms of how we connect. The CBOs are valuable. Pharmacies, health homes, wellness programs that are out there, we try to incorporate all these systems and come up with different arrangements for them that often helps not only you, but the community. For us, it was interesting. So in 2012, we submitted we wanted to be a health home. We didn't know what these things were. Listen, we're primary care doctors. We can do a health home. So it's funny because we started it. Today, we're the 6th largest health home in the state.
Yeah.
And our numbers are the best in a lot of things because primary care doctors are really guiding what goes on in this model. We're the only health home that has NCQA case management because we wanted the systems to kind of learn to see if it works. We're the only health home that had a certified medical record, which to me was shocking. Everybody had their own out-of-the-box models, creating their own, and then you find yourself kind of trapped when you were given resources to really build something nice, but you chose not to use the resources wisely. Informatics are key in this whole process. How you really tie things, how you redevelop and redesign our systems. One of the areas that we're implementing in 2 weeks is actually a telehealth platform. We have telehealth, and it's using care coordination in terms of virtualizing management. So all our quality metrics, all the preventive services, all diversion from ER utilization, we're using care coordinators that can actually channel information in, and providers can actually use remote tools like TytoCare. So you can see the ear, listen to the lungs, get temperatures, everything remotely, and having someone there to kind of just get that information to you, creating e-visits and not really having those individuals coming into the office, and developing a structural contract to do global, so that it includes not only a visit in the office, but a visit that's tied into telehealth. And that's how we, as providers, as systems, can really redefine what goes on. These are just more. Real important in this process too is predictive modeling and really getting a better idea on how we assess risk. I think as providers, we see and we just bill, right? CPT codes 99213, that's okay. But we don't really do well with the ICD-10s. Because you know what, it doesn't affect us. We get paid. Well, I'm going to show you that that does affect us, and it changes the whole model. And the wiser we get in that model, it's going to really help us in terms of the impact and dollars that come back. And our doctors learn. So accountable care, there's an atlas. This is how you get there. I have other slides to give you. I'm going to go into little separate sections, the commitment to it, how do you educate, these areas that I kind of highlighted, because to go the other route, it's going to take us a lot longer. So in terms of our commitment, we actually went with this. So we applied to the state to become one of the value-based pilots. There were only 9 in the state. We were the only one in Western New York. We created an agreement. We chose an insurance company, YourCare, which was a Monroe plan from Rochester, which in the beginning, both of us kind of looked at each other, you know, who's going to hit who first? But we became the best of friends. And I could tell you, that was crazy, because they wanted to get the same things we wanted. But I think the more we learned about each other, the better we got, and that was real important. So we created we were going to do a 3-year agreement, but then the state came back as a pilot and said they only wanted 2 years in terms of the agreement. First year, well, I'll show you what we did in terms of what the contract was consisted of. So again, costs, the quality metrics, we picked 12 quality metrics, and we wanted to maximize the risk stratification. And I'll show you why that was so important. I'm going to jump over the areas. These are the quality metrics that we chose. So we chose them. We actually put the numbers on them. We looked at the core scores. We made sure that we can hit these, and that was it. We told them the 15. It wasn't like they decided that we were going to do these things. It's better for us to kind of pick our own kind of models. And if you look at MACRA and you're in the MIPS program, they're picking your models. APMs, you decide. I always like to decide what my numbers are. I don't like people telling me that, you know, because they might not have a good idea. So that happened there. We needed at least 12 of these measures to get 100% of the share savings. So, and I'll tell you how our model kind of worked. We had a 2-year pilot with the state. They allocated some money. We had 10,000 lives, so this is what they predicted initially. But you know, the state ended up giving us close to $2.3 million, which helped to kind of establish the relationship between the two entities, and we all used our money differently. For one of us, we chose, well, you know, if this thing goes bad, I got a lot of primary care docs, right? I don't want them disillusioned. So how do I make them happy? So I said, well, let's come up with a model that we said, you know what, we'll give them $5 PMPM based on the population per month. It helps with retention. At least they see some dollars, and if things go bad, they get something. So that's how we chose to use our side of the dollars. They chose to use their side of the dollars basically to leverage their IT and other aspects of it, and we were okay with that. This is the agreement. And it took not too long to come up with the agreement, but this is what you want to look for, and you push them. They don't like to be pushed, but you push them. And here is in the first year, we wanted 89% of the medical loss ratio, 75% of the dollar adjustments, the 5 PMPM we were going to give our primary care. It was a 50%, 50-50 in terms of share savings. No downside risk for the first year, okay? and we got a $275 case management. You can negotiate a 1 or 2%, because we needed operational dollars in order to sustain this. That was our first year. After the first year, we made $575,000 plus the $275. That went back to the primary care doctors. We divided it up. And we weren't able to really finish the pilot in the first year because we only had 9 months. The state started late, and then they wanted to backlog us for the extra 3 months. So that's how we did the first year. Second year, we're going to be doing a little bit of a different model. Here, we want 100% of the adjustables. The 5 p.m. remains 60% on our side, and we're putting $500,000 in terms of our deficit. We still get our case management dollars. Now, interesting enough, so the $5 PMPM that we agreed to was actually, it comes out to $650,000. So even in a bad day, all they do is keep their money. We don't lose. But we took on a $500,000 risk. And presently, we're actually doing fairly well on the models, and I'll show you some of the information. So I think the social determinants of health we talked about become real important. We focus on transportation. We're doing housing in terms of that. We have pantries, wellness, other things that we're tying into this thing that just came about by the services we have. Now, the biggest thing that you have here for us was we had a lot of different entities that have never worked together in a value-based agreement, and that was a little bit crazy. So we have an IPA, 8 docs that know each other. We have Western Medical Group, which has 45 docs that work under one umbrella. We had Jericho, FQAC, they work in their model. We had a Safety Net Hospital, ECMC, they work in their model. And then a Buffalo General that does more commercial Medicare model. And we took all these different primary care. Now, the reason we did that was in order to get into the value-based pilot, Your Care wanted to play in this model, but they were new to the market, and we needed 10,000 lives. So what we did was brought everyone that had major lives to kind of develop a better contract. The problem we had with that was we had mature systems that had IT, informatics, and population tools, and hospital systems that don't have those things at all. And how do we play with that in order to win so we don't lose? So that was a challenge. We built teams. We built the value-based team that was basically not only working for our teams, but helping develop value-based models, which in each of the institutions that we were playing with. Informatics. This electronic record is a really good one. MedDen is by far the system that, as a doctor, I've been using it for 22 years. So I haven't changed my electronic record, and some of you guys have changed 2 or 3 times. It has really developed and really developed a lot of formats, and really it helps practices kind of learn. And what's nice is I can have one of my people go in and standardize anybody's electronic record to do the same things. I thought that was real important. So a couple things with the dashboards. We needed daily information, provider comparison, and we wanted to follow trends. Now, this is a dashboard that's available, so at the practice level, we would actually help the practices develop their own dashboards, so they would see their trends. And if you're looking at this, you start to see trends for blood pressure, trends for everything else, and when you know your numbers, you know to improve. You can drill down to the provider, drill down to the patients that you have, all at the practice level. So you didn't have to really do anything else, but just use that particular system. When you look at the other 2 forums, the other forums that we had, because we had provider groups, we had the ACO group that meets to kind of look at our quality, to see if we're saving or losing money. I used 3 different formats as a result of that in terms of making sure that they didn't get lost in the data. So Tableau helped to do, it was a nice format because I can have the insurance company give me an extract of this information, and we digested it here to look at our quality metrics. So these quality metrics are where we're at with some things, okay? And this was for the whole. We have a few amounts of lives to kind of tackle. We've got the teams going. We're on track for 10 out of the 12 right now, 10 out of the 15. Some of these become a little bit difficult. Colorectal, we're trying to grab everybody. And the stools, we have So what we did with the quality teams, which was interesting, is the mammograms. We have a member that runs a mammogram unit, imaging, that's part of the ACO. We just give them the list. We said, here's you go hunting. We have colorectal surgeons, Here's your list, go hunting. So it makes it a lot easier for us to kind of manage some of these quality metrics. The rest pretty much do pretty well, but we're on track for 10 out of the 15 right now. Clinicians was good because this helped me to kind of do a couple of things, and we were the only pilot in the state to have this type of tool, by the way. And we have a presentation that's out, that'll be out in the next couple of weeks that the state has. And listen to it, because we went into a lot of details with regards to this. I won't be able to cover it in detail, but Clinigen was an aggregator tool that we started with, and I needed ways to grab the data, okay, in order to not only aggregate, but push it out to the insurance companies, which is key, but also tied into the real, because there's so much information in the real that the hospitals are dumping into that we really don't have access to. And as a result of that is, for example, hemoglobin A1C is done in an emergency room, but they bill a global fee. That information was never billed. So you can't scrape it because they send you a PDF. It's a problem. But that information is in the real. And we were able to kind of help with the gap in some of these things that we were missing. So that was one of the things. The QMX tool for us was really, really cool because this one allowed us at the top level. And it was funny because we actually meet with the hospitals, which we knew more about the hospital than they knew about themselves. And that was shocking in terms of you're operating these systems and you got to really know your bottom line. And this system was able to kind of really give us a better idea. See how simple this is? It tells you where your savings are for a time period. And once you press on any of these things, you go down and it drills down to everything. Examples, this is just an example of the buckets we talked about. It's not as clear, and I'm sorry. But the inpatient, outpatient, professional and pharmacy costs, you can see trends. We can drill it down by hospital, by individual, by provider, and you start to see it. Whether you want monthly, quarterly, yearly, that data is available. And 30-day lag, which is not too bad. When you look at the other aspect of it, we start to see the quality reports for the providers as they get laid out. We get to the point where we can actually have scorecards in the providers. We can tell them exactly what they're lacking, where they need to improve, how to compare themselves to other providers. Because if you ask all the providers, everybody has the sickest patients, right? Here we know. And a lot of times, some doctors do have sick patients, but they don't code right. And as a result of the coding, it throws us off, and the coding can really change things. As part of the pilot, because of our coding, this year in April, our insurance company, YourCare, got a 5% premium increase. And that premium increase gets split between them and us. This gets into the point where providers sometimes don't code the way they should be coding, and even cardiologists aren't coding, essential hypertension, instead of giving it a particular, hypertensive with heart disease. If you don't do that, it doesn't tabulate the risk score, and that risk score can be significant. Our practice IPA risk scores were about 4.0. Jericho, which is a FQAC risk scores of 1.2. That risk score means how much you get paid in terms of going forward, and it changes the model in terms of what you're expecting to get as a result of the deal. This one's imaging. You start to see who's ordering imaging, for what reason, are they following the guidelines? You can really drill down to make sure that what gets done is following some sort of a protocol. This is information we never had. So you were talking about risk scores. It ties in 3M and Johns Hopkins ACG. These are algorithms, like you said, that have been calculated to tell you who's going to need case management, who's going to cost you money, and if they're going to continue to cost you money. That predicted analytic models are already built into this software. Okay? These are just examples of where pharmacy is, how much you get into the generic areas. We were able to change 8 drugs. Not a lot of stuff in terms of changing. We're talking about going from like maybe Symbicort to something comparable and save $2.7 million. Didn't have an impact to us initially, but now it does. And as a result of that, we also built into the electronic systems ways to teach them that if you're going into a drug and you got choices and there are 2 ARBs, and this ARB is here and that, make a decision. If they're going to both give you the same outcome and you've seen, why not go with the cheaper? This is our design, and this is what we kind of put together at Jabak, and we were pretty unique. So we brought in all the contractors. Everybody had their own system. The ones that had the electronic record, MedDen, that was good. But then I had Cernas and the Allscript and all that craziness at the hospital level. And you know they're going to expend more Cerna and expend more money, 200 million, 300 million. We don't have that kind of money to spend. So this stuff tied in, and we use what I was able to get our Rio to kind of filter the data in and put it into our aggregator. Our aggregator was also pulling in MedDen data. It was able to give it to the insurance company, and the insurance company was able to give data back in order to use the quadmetrics. But the key thing here for this is because of the information we were able to rip off of the Rio, they were able to improve the HEDIS scores quite a bit, about 10%, 10, 15%. And so that's where things kind of change. I'm running a little bit, am I good on time? Okay. So here in terms of, this is what we try to do is break it up by the categories that we deal. Okay, good, I think I got time. I was trying to, am I talking too fast? I'll slow it down, I'll tell you what's So, you know, this is a particular area that we talked about, was we actually, we created integrated models in terms of committees between the insurance company and us. We're not different anymore. We're pretty much the same. We sit at the meeting and we look at ways to kind of save in terms of practices. So one of the quality metrics was behavioral in terms of antidepressants. You know, you get dinged if you don't have that 3-month. So we said we need 90-day tablets. Everybody gets 90-day tablets on hypertensive, diabetic, everything is 90 days. And at this meeting, they said, well, it improves our quality metrics, done. There was no like no's, because at the end of the day, I always say people in the system have an opium problem, other people's money. But when it's your money, you get real smart about it. And that's what we did with the insurance companies was, if we all save, the patients get good care, and we do what we're supposed to do. Not get caught up on not doing things because we don't get paid for those things. That doesn't work for me. So that worked well. We develop, you know, a lot of times you have doctors, they write the prescription, it goes out the door, doesn't make it to the pharmacy, so you get dinged for it because there was never a claim attached to it. And as a result of that, you look like you're not doing a very good job. So our care coordinators with our transportation system actually takes care of making sure that those patients get the medication filled and that it gets delivered to the patient. And as a result of that, that's where a lot of the quality metrics change when you're being more engaged in that. These are just areas that we kind of integrated. I think for us, the telehealth and the care coordination and a lot of the contact center that allows us to we're creating a quasi-Amazon type of system, which is important because we start to learn what the patients like or dislike. At the same time, it creates some loyalty to the system. So we've got applications like apps and things like that, but all helping us to kind of achieve the goals which are important. I said about risk scores being important, so important. So just as an example, Medicare pays about $800 PMPM, per member per month, for a diabetic code. Let's say the old codes were 250.02, unstable diabetes. I forget what the new codes are because I don't do too much of that anymore. I got people. So if you have someone with chronic kidney disease, that they check on the labs that have a creatinine clearance of 2, and that code gets adjusted to the 250.42, you're talking about $27,000, which come back, and now you can use to kind of do other things for that member. So I think you know, eventually what I find with the value base is it's allowing us to kind of value ourselves, because if systems right now, I always tell hospitals, you know, you can continue running your fees the way you want to because you're already at risk, more risk than you know. At the same time, we saw based on our systems, like our safety net hospitals, have about a 30% avoidable ER visits. They're coming in for sore throats, earaches. So now that they're partners, we have simple solutions for that. The opium problem goes away because all I tell them is, now that we're partners, I'm going to pay you a clinic rate for that sore throat. You're not going to get an ER rate. You know how fast that corrects the problem? They develop a bypass system. Now they have a fast track. And we all do fairly well as a result of it, because the doctors also said, listen, we all got to start kind of managing this population a little more effectively. Because at the end of the day, it's building a system that's sustainable. And I think with these models, we can become sustainable. So that was it. Okay. Thank you.